So welcome everyone to the Neuroanatomy, Comprehensive Neuroanatomy Educational Program organized by the Yemeni Neurosurgical Society in collaboration with the WFNS Young Neurosurgery Forum, Pakistan Society of Neurosurgeons, Neurosurgery Couch, and Neurosurgical TV. Today we have our 16th webinar of the Module 4 about spine and spinal cord. Today, Dr. Adnan Awadi is a consultant neurosurgeon and one of the few spine surgeons in Yemen that can do deformity spine surgeries. He will be a chairperson of today's session, and he will welcome Professor Dr. Nikolay Peev, chairman of the WFNS Spine and Rehabilitation Committee, and one of the best spine neurosurgeons we have. So, Dr. Adnan, please, you can start.
How are you, everyone? How are you, Dr. Nikolay?
Thank you, Adnan. Very good.
Dr. Nerjiza, nice to meet you
Hello,
all.
sir. Thank you.
Dr. Nikolay is the head of the spine committee in the WNFS, and he's one of the best endoscopic spine surgeon in the world, and also in the United Kingdom. Dr. Nerjiza is the founder of the neurosurgical ground round in Russian neurosurgical ground round. Nice to have you all, and we will start our topic today. You can proceed, Dr.
Okay. Thank you so much. Dear Adnan, thank you so much for the nice presentation. Yes, I can hear you well. Thank you everybody for being and for being here on that webinar, and thank you for willing to listen to my lecture. So I'm going to talk to you about monoportal endoscopic approaches. So in general, now we see, you can see from the following slide, there is many different types of endoscopic approaches and surgeries now. So I can see how the endoscopic spine surgery is nearly shaping to become a separate subspecialty soon. I definitely see that happening at some point. So endoscopic techniques, uniportal transforaminal approach, uniportal interlaminar approach. So I'm gonna also show you transforaminal transcambient interbody fusion approach. So these are all uniportal techniques. So before I start doing the endoscopy, I just wanted to disclose that to you. I had about 400 minimal invasive TLIFs. I've done many injections. I will show you and I will tell you what is the significance of doing injections if you want to start endoscopy. We started uniportal endoscopy with my work partner, Mr. Ashraf Abu Harb, in 2018, and endoscopic fusion we started 2024. So surgery the endoscopic surgery is not easy, but it's not very difficult to get in your hands. Depending on your experience, you can get it relatively quick. We have a good paper on that from Paulo Pereira and Silva from Portugal, who has calculated that you need about 50 cases of all these minimal invasive and endoscopic procedures in order to reach your 90% milestone. So your 90% milestone is somewhere here. With 50 cases, you're still novice. You start to understand the surgery, but just about that. So, and then we talk about steep learning curve. You can see the learning curve is steep. That's why the learning curve is steep, because every time you want to go to the next level, you have to double your cases. So 50% is 90% milestone is 50 cases, but from 90 to 100%, you need another 50 cases. So you need to double your cases and in order to really call yourself expert, you need about 200 cases. And this is only when you start really have a good insight of the technique and all the implications. So I'm going to show you, I'm going to start with a case of one of my cases. You can see this is 49-year-old female. She is very active, previously running marathons, but lately she cannot do that. She's complaining of neurogenic claudication. The MRI scan shows grade 1 degenerative spondylolisthesis. And that was my solution for that. You can see this is a video that's demonstrating transforaminal monoportal transcambin fusion surgery. So basically, this is the port that I'm using, and this is the cage that I'm using. I'm using expandable cage that is being collapsed, is 8 or 10 millimeters, and goes lengthwise with increments 22 to 34 millimeters. You can see from the video, you have all different kinds of instruments to make the discectomy. Expandable reamer at the minute. You have pituitary rongeurs. You have curettes. You can see here, which is helping you to do a nice clearance of the disc and the end plates. You can see this metal. Sometimes I use these metal brushes. And then the final stage is going to be deploying the spacer, the cage. You can see the cage is being deployed and then expanded. You can reposition it. That went a little bit too far. And then you can expand it and you can leave it. So that technique is not necessary to put your cage straight in the middle because that is providing indirect decompression. You can put the cage slightly off center depending on what goes you have. Actually, if you have lateral listhesis or scoliotic deformity, it is desirable to put the cage a little bit offside in order to correct the deformity. So all of these techniques are technically demanding techniques. As I said, you need about 200 cases to really understand. You have still other challenges like screw precision, always there. Percutaneous screw, obviously, if you're doing percutaneous cage or percutaneous fixation, you have to put percutaneous screws as well. The nerves are always at risk anytime you perform transforaminal approach. If you do fusion, obviously, if you don't have open technique, fusion rates depend on how meticulous you are with preparation of your disc. And radiation exposure is always a problem with all the minimal invasive techniques because you don't have your landmarks when you open the body. Normally with the open techniques, you have the anatomical landmarks. You don't need so much X-ray, but with the minimal invasive and the endoscopic approaches, X-ray is your eyes. So you have to be very careful and considerate how you are using the X-ray. So this is the area where normally we are trained to go with the classical approaches. This is the mainstay. This is how we are trained to do throughout our residency programs. This is what is the comfort zone for the majority of the neurosurgeons performing spine, even nowadays. So this is the area that you normally would skeletonize. This is the area that you would go, and this is where you work. With the endoscopic approaches, with the transforaminal approach, you go on the other side of the facet, you can see, and this is the area that you can achieve. This is roughly the area that you can start with. Of course, later on, when you're more experienced, you can do extended and you can do advanced approaches. You can contralaterally and do contralateral disc herniation. But for start, you're going to be in that area. And this is your perspective. This is the triangle that you use to do your approach. This is where you put your instruments in order to do discectomies and even fusions. So it looks like it's a very tight place, but with a proper technique, it could be developed, and you can do all different kinds through that tight place here. So understanding the anatomy of the Campbell's triangle is of utmost importance for you to be possible to do transforaminal approaches, monoportal transforaminal approaches. So let's start. This is probably one of the most important slides that I want to show you. And if you would like to memorize one thing from my lecture today, is that slide. And if you understand that slide only, I will be very happy. So your lower end plate is your best friend. This is what I mean. So you can see here, this is the neuroforamen. That is, the perspective is oblique, and you have to enter that tight space here. So medially to the exiting nerve root and above the lower pedicle, and then below the superior articulating facet. This is where you have to start your approach, and you have to develop that space in order to be possible to perform surgery. So the first step of every transforaminal approach is docking an instrument. Usually that will be a spinal needle or a small dilator, but this is where you start. You start at the base of the superior articulating process and the junction with the pedicle. So this is the most important point when you start your transforaminal approach, and that is a point that is aligned with the lower end plate. That's the importance of the lower end plate. And that side of the slide is explaining why it's important, because of the oblique course of the exiting nerve root. If you are close to the lower end plate, this is the situation that you have. You go medially to the nerve root, to the exiting nerve root. But if you are going up, if you dock your instrument somewhere here, when you start going in, you're going to go straight to the nerve root, and you're going to damage the nerve root. So your patient will be paralyzed, or at least will have a radicular, let's say if that's L5-S1 or L4-L5, your patient will have a foot drop. So this is the importance of the lower end plate. Always remember that your surgery starts at that point, and that is aligned with the lower end plate. So before I continue, I have to stress the importance of the way how you understand and the way how you read the X-rays. So you should be possible to have a very good understanding and reading of the X-rays without hesitation. You have to be possible to discriminate without any problem the transverse process, the pedicle, the spinous process, all the end plates, and the facets, and everything that's important, and that's corresponding on that side. So the other thing that I have to stress, and that is of utmost importance, is that you have to make sure that your X-rays are reliable. So the X-ray is reliable when you have true AP image and true lateral image respectively. So true AP image is an image that you see the spinous process. You see the spinous process right in the middle between the two pedicles. You can see the spinous process is equidistant to the two pedicles. And then the other most important thing is, if you're operating that level, for example, the end plate of interest has to be lying. This is only when the end plate is in an orthograde, true AP direction. And if you see your end plate as an elliptical shape, then this is not a true AP X-ray, and you have to ask your X-ray technician to go up and down towards lordosis or towards kyphosis in order to give you true AP X-ray. So that's the importance of the true X-ray. If you don't have true AP X-ray or true lateral respectively, you will dock your instrument somewhere that you think you are, but that's gonna deceive you because of the phenomenon known as parallax. If you are not true AP or true lateral, if you don't follow these simple rules, you will dock your instrument somewhere that you don't want to. And the same thing again with the true lateral X-ray. So if you are operating that level, this is good because the lower end plate is a line. Lower end plate is a line. And this is a good picture. This is true lateral picture for that end plate. But if, let's say, you want to operate that one, and if you see elliptical form, elliptical shape, that is not a good shape and that is not a good form. So you have to be very careful with that. And again, same thing applies. So if you dock your instrument here, you know that you're here. But if you dock your instrument here, you might be completely different place. So it's very important for you to have true lateral X-ray, especially in the beginning when you're docking your first instruments. The other thing that is important for you to understand is when you're performing the monoportal transforaminal or interlaminar approach, everything is about trajectories. So you have to, if you calculate properly your trajectory, that is a function of your entry point, you will have a successful surgery. And the other way around, if you calculate your entry point in a wrong way, and if you have a wrong entry and then respectively a wrong trajectory, it's going to be very difficult for you to perform your surgery, and that's a recipe for disaster. So when you start going through different courses, they're going to tell you, or maybe you read book, and they're going to tell you that in order to achieve the transforaminal approach, obviously you have to start from the flank of the patient, you can see here, with a certain amount of offset from the midline. So they will tell you that if it's L5S1, it's 12 to 16 centimeters. If it's 4-5, it's 11, 14 centimeters. If it's 3-4, it's 8-10. But how is that possible to be same for somebody who is 60 kilograms, for example, or somebody who is 120? Obviously, that's not possible. That's why with the years, I have drifted away from these numbers. I don't like to remember numbers. And I try to remember specific landmarks and specific points. So I'm using that three-color system. You can see on lateral, I have this three-color system. I have the blue zone, which is above the supraspinous line. So you build on lateral line that is corresponding to the supraspinous line. And that line will be somewhere here. That's going to be the lower end of the blue zone. And then you can see the top end, everything above that is a blue zone. So here you're in the blue zone. So then if you want to be in the green zone, you have to build another line. So the line is the suprafacettal line, So the suprafacettal line and the supraspinous line is locking the green zone. And that's your entry. You have to enter in the green zone, somewhere in that zone, in order to be in a favorable position and trajectory to hit one of these foramina, one of these intervertebral foramina. So you have to start your skin incision somewhere in this green zone. And the red zone is anything that's below the suprafacettal line. So you don't want to go there because you don't want to go in the abdomen and damage abdominal organs. So green zone is the zone that's desirable for you to start with, and at least. And if you develop that technique with these three colors, you don't need to remember centimeters, because one day they're going to be not right because the patient will be too small or too big for these centimeters to work. So same thing here is demonstrated on an axial cut. You can see the blue zone, you can see the green zone, and you can see the red zone. And you can see how if you are in the green zone, your axis and your trajectory is favorable. So you can access disc herniation. You can access more medial disc herniation, more lateral, far lateral disc herniation you can access, or you can go in the disc and do discectomy and fusion surgery. So you know why the green zone is not working, and you know the blue zone is going to be too steep, so it not be possible to go in the disc. So in the blue zone, at the end of the blue zone, only if you have extraforaminal disc herniation. In that case, you could be in the blue zone. This is the planning that I do. So you can see that I'm marking the midline, and I'm marking the center of the disc, and I'm marking the center of the disc on lateral, marking center of the disc on AP, marking center of the disc on lateral, through AP, through lateral, remember that. And I usually start somewhere halfway through. That's a good point. That's going to be your point, and that's going to get you right in the foramen. And because the skin is movable, you can move your instrument up and down a bit, so you can access a lot of pathology here. So this is a good start for you. So center of the disc on AP, center of the disc on lateral, and then go in the middle. That's a good start. The other thing that you have to be very careful is, as I mentioned to you, trajectories and how you're advancing your instrument. So again, this is what you're going to see in your theater, but that's what I'm going to see on X-ray. You have to always track your instrument. The first instrument usually will be a needle or a small dissector, as I mentioned. So you have to track the instrument always on AP and lateral, and you have to see how the instrument is advancing. So this is the end point of your needle. You can see that, let's say, or your instrument on lateral is now on the posterior vertebral line. And here on AP is just short of the medial pedicular line. Medial pedicular line, that's the line that is medial to the two pedicles. You can see the pedicle, upper pedicle, lower pedicle, medial pedicular line. And you can see posterior vertebral line that goes at the back of the vertebra. So this is the posterior vertebral line. So this is your starting point. This is what you are aiming when you're docking your first instrument, whether this is a needle, whether this is a key wire. So, and this is the situation that you're facing. You can see that your needle is just short of the medial pedicular line and just on the posterior vertebral line, means on the disc. And this is the anatomical correlation. You can see that the instrument is medial of the exiting nerve root, lateral to the dura. That's the significance of just lateral to the medial pedicular line, because medial to the medial pedicular line is the dura. So dura is medial to the pedicle, so then is medial to the medial pedicular line. And if you stay just lateral or on the medial pedicular line, you are safe. You're not going to go through the dura. So this is the anatomical explanation of these two very important X-ray landmarks, and this is how they should be interpreted. So this could be a good picture as well. If you would like to do fusion surgery, you're entering here the disc on AP. You can see you're lateral to the medial pedicular line, but on lateral, you're already inside the disc. So this could be a favorable picture in case you would like to do transcumbent fusion surgery. You have entered the disc laterally enough, so you are not going through the dura and you are not damaging the dura. This obviously will be a bad situation. You can see here on lateral, you are on the posterior vertebral line, but on AP, you are crossing significantly the medial pedicular line. So you can see that, and you understand why you would be in the dura here. So if you realize that docking your needle, that's okay. You have done just a lumbar puncture. That's not a big deal. But if you don't realize that situation, and if you start after that trading your dilators, then it can cause a quite significant damage to the intradural structures, and then your patient will be in trouble and you will be in trouble. This is obviously also a bad picture, a bad situation. You can see on AP, you are short of the medial pedicular line, but on lateral, you're way past the posterior vertebral line. So likely you're too steep. Likely you are entering the abdomen, and it may damage important abdominal organs, and it may cause serious troubles as well. So same thing applies. The first step was the needle. After that is dilator. You can see after you your needle appropriately, which is the very first step and the most important step, you start putting dilators to develop the space. We'll expand the disc in case it's in the disc, and also will push the exiting nerve root laterally, and like that, it will save it, it will preserve it. So after you dilate, then you put the working cannula, and the position of the working cannula should be with the bevel outside. But you put the bevel inside in order to prevent that bevel to cut the nerve, and then you turn it. That's a very important maneuver as well. When you're sliding your working cannula, you're sliding it with the bevel inside. So like that, you're not gonna catch the exiting nerve root. And then once the needle is, when the cannula is fully in, then you rotate it. This is very important. This is the trajectories that we follow, and this is the transcambing trajectory. This is the transcambing trajectory that we follow with the transforaminal monoportal approaches. I just wanted to say a few words about the decompression, and I have mentioned to you that and the first case that I showed you was transcambing fusion surgery. Obviously, the fusion is not relying on the direct decompression. You can see here on that left-hand side, this is how the nerves look after I have done minimal invasive transforaminal lumbar interbular fusion. This is the bony work that you do to do minimal invasive TLIF. With the transcambing fusions or with the transcambing work, you don't have that. You cannot do all that bony work, so you rely on indirect decompression. However, the indirect decompression, as it appears, is very potent thing, so you have to accept that seriously and think about it. And this is the rationale behind that. When you reduce and when you extend the disc, you unbuckle the ligaments and you create more space in the foramen. And the foramen is cylinder. Remember, the foramen is a cylinder, and if you increase the radius of the cylinder, which you do when you do indirect decompression, you gain a lot of volume. You gain a lot of volume because of that formula. So this is the rationale behind it. And because I don't have the way to put bone inside the disc, because I'm not harvesting any bone or any other materials, normally when I'm doing fusion, I put these tricalcium phosphate granules mixed with bone from the vertebral body, and that works well for me for fusion. With that technique, you can even put 2 cages in one through one neuroforamen. You can see this is how it is done. It's a quick video to demonstrate that to you. You can see that I first pushed 1 cage and then I pushed the 2nd cage. This is useful technique in case you have a big patient with poor bones, as this patient was, you can see here. And I had to put 2 cages in order to prevent subsidence. And you can see that this is you can push even 2 cages through 1 neuroforamen. So very potent technique. So you can do a lot of things through that single and small neuroforamen. It's not very small. You can develop it and you can become a big space and you can do many things through there. You can see comparison between different techniques. And so this is, for example, minimal invasive TLIF or or even open TLIF. This is the standard cage that you have with about 380 square millimeters surface. With the standard PLIF, you have about 500 square millimeters surface. With a TLIF, with a transcambing TLIF, you can have better situation than the PLIF that has 2 cages. So potent technique and reliable, and you can do many things through a single neuroforamen. So, other factors when you start developing your approach, transforaminal approach, whether this is for simple discectomy, whether this is for fusion, you have to have good support team. Like scrub team is very important. They should know what you do and they should support you. The anesthetist should know what you do. The radiographer should know what you do. And then in the beginning, for the first cases, you may have faculty surgeon. First cases, you try not to choose very complicated first cases because you're going to have problem when you're going to stop and you're not going to continue. So if your patient has quite significant foraminal narrowing, then that might be a difficult case for you for a first time. It could be possible to do it later on after you perform. This case will be done if you have at least 100 cases transforaminal approach under your belt. This, however, is something that you can do. The other thing that you have to consider is the iliac crest. L4, L5 is always okay with men and women with respect of the iliac crest. However, L5S1 can be tricky. So L5S1 is not at level for your first 20, 30 cases. I would say even 50 cases. So probably L4, L5 is your level of choice for at least your first 20, 30 cases. No degeneration, large foramen, no anatomy variations. And be prepared for complications. You can see that I had a few complications as well. This is a broken cannula. It broke inside the patient, but I managed to fish it out. I've lost a cage in the abdomen, but luckily it was just in front of the psoas and posterior to the iliac veins, and it's not creating any problems. So I just left it and it's not creating any problems. And because this is how the skin looks after transforaminal fusion surgery. These are the cuts for the screws, and this is small cut for the cage. But because it's too small, in the beginning especially, you tend not to stitch it properly. But you do need to stitch it. You need at least 2 layers here, otherwise it's going to open, you're going to have infection. So it's not good for you to neglect that. I mentioned to you about the radiation. Radiation is very important, and you have to use it to all these minimal invasive cases, and you have to be considerate how you use it. So if you're not very stupid and if you're not keeping your hands under the beam, you don't get direct radiation, okay? You don't get direct radiation unless you see your hands on the monitor. So if you're seeing your hands on the monitor, obviously you're under the beam. That's a very stupid thing to do. Try not to do that. Try to stay away. So you get indirect radiation. You get the scatter, the radiation that bounces back, that is bouncing back from the patient. That's the radiation that's dangerous. And the bigger the patient, the more scatter you're getting. You can see from that diagram, you can see that if your patient is bigger, if the patient is obese, you're getting more radiation. So you have to be more careful with your bigger patients. Also, if the patient is bigger, the image quality will be poorer, so you're going to do more x-rays. So be careful. So you can see here, that's the same thing. The scatter is what's important. If you orient your x-ray appropriately, so the intensifier is on top and the source is at the bottom, you don't have so much radiation. The radiation is under the table. So that's a very important slide. You can see that if this is the x-ray tube underneath and this is the receiver at the top, most of the dose is at the bottom below the table. But you usually you're normally going to use protective gear, so you're not going to get so much radiation. Also, another thing that you have to see, and that's a very important slide for your radiation protection understanding, is that 30 centimeters makes big difference. You can see here only 30 centimeters, and the dose has dropped. The dose has dropped 4 times. So if you make just even one step when you're x-raying, one step back, if you see me operating, if you see me doing my minimal invasive surgeries, you're going to see me constantly dancing back and forth. I don't like to hold the instruments when I'm x-raying. I've developed technique to prevent me from holding the instruments. So you can see me that anytime I say x-ray, I would step first 1 step back, And this is why I'm doing that, because if I step one step back, I'm 40, 50, 60 centimeters back, and that is bringing the dose 1/8 of what it will be if you are close to the patient. The other thing is you have to choose wisely your site. On lateral screening, you can see that if you're on the site of the X-ray tube, you're getting 8 times, 16 times more radiation comparing to if you are on the contralateral side. And if you remember why is that, because this is the tube, this is where the X-ray is generated, and it goes to the body. Some of it goes through and goes to the receiver, but some of it is bouncing back. This is the radiation that comes to you. And here, bounce back is quite significantly higher comparing to here. So same thing again, choose your site. It's a very important paper from Korea. And that's what I told you. This is the most stupid thing that you can do. This is my hand. I did it not because I wanted, but because the X-ray technician took X-ray before I remove my hand and before me asking for that. These things will happen, but try to minimize them to as less as possible. With regards of the paper, there is a paper coming from South Korea. You know, South Koreans are very high, and they're very, very big in minimal invasive and endoscopic techniques. So they use that a lot. So there is 2 detectors. One detector is right on the side of the body. That's detector A, and it's wrapped with a lead glove. That detector A is wrapped with a lead glove. Detector B is only 20 centimeters away from the surface and is not wrapped with a lead glove. So they made a trial, and they found out that detector B, that's not wrapped with lead glove and is only 20 centimeters away, is getting less radiation comparing to detector A that is wrapped with a lead glove. So what's the moral of that story? Even if you are with a protective protective gear with lead apron, if you stay right at the side of the patient, you're gonna get significantly more radiation, and it's a very simple way to reduce your radiation if you step back with 1 or 2 steps. Just remember that, because this is very important. Protective gear, very important. C-arm position, very important. The so-called hostile positions. If you are 3/4, try to stay again away from the tube. And distance is the most important thing. Collimation is very important. If your X-ray technician is very considerate, he will do collimations every time he does X-ray for you. So like that, you will see only the object that you need, and you're going to reduce the radiation. I ask my X-ray people to mark the X-ray, mark the floor as well, like that when I'm going in different positions. If I have to shift to AP or lateral, they know how to go straight to the same position that they had before. And like that, I reduce the unnecessary, useful, and so-called parasite X-rays. So this is also a good way to reduce your dose. Position in the theater also very important. Some colleagues are using 2 X-rays when they do AP lateral. I tried that, I didn't like it. But there is surgeons which are doing that, so you may try. And that was it for the for the transforaminal approach. I will give you a few words about. Do I still have time? Hello?
Yes, Professor, you have as time as you like.
You have
Yes,
time,
sir.
Dr. Nikolay.
Should I continue?
Yes, please.
Yes, you can. You can.
All right. So uniportal and full endoscopic interlaminar discectomy. Again, this is the area that we go. This is area that we are trained. So that's why some people are finding the uniportal interlaminar approach more amenable, easier to start. So maybe you may consider interlaminar before your transforaminal, if you have some endoscopic experience already. So this is some background information that you need to know. You have to remember that the intervertebral, the interlaminar space is going smaller as you go up the lumbar spine. So as you can see here, L5-S1 interlaminar space is 8 millimeter. At L4, L5, you can see here is getting 6 millimeter, etc., going smaller. So probably if you're starting the interlaminar approach, L5-S1 is your level. Remember, on lateral, the transforaminal, L5-S1 is not good for you because it could be obscured with the iliac crest, especially with men. So if you are starting your transforaminal approaches, L4, L5 is your level for your first 20, 30 cases. If you're starting interlaminar monoportal endoscopy, your level of choice for your first 20, 30 cases is L5-S1. So again, necessary anatomy. This is the anatomy that you consider. You can see the window here is the biggest, and then it's getting smaller and smaller and smaller. So this is sort of a planning that you do. You go on lateral. Usually I put a needle, and the needle is aligned with as you can see, the needle is aligned with or instrument dilator is aligned with the end plate of interest. So that's the planning. Planning here is significantly easier comparing to the transforaminal. Usually you do less than 1 millimeter of the midline. That's to slide it just on the site of the spinous process, because remember, especially if you have a skinny patient, spinous process is occupying some space from the midline. Okay, so you go just a couple of millimeters off the midline. That's your planning. Very easy to do, very easy to go. The first step is dilator, and then after dilator, you introduce your working cannula, and then you start working, then you scope. And this is the first picture that you're gonna see. You're gonna see the yellow ligament if you are lucky. If you are not, you might see just muscles that you have to cut, you have to develop, and you have to see the yellow ligament that you have to, after that, penetrate. Usually you penetrate it just at the edge between the two laminas, so-called V point. So you have to clear nicely the V point. This is the inferior, this is the superior lamina, and where they are meeting, this is the V point. This is the V point here. This is where you're docking. This is where you're starting. So this is where you have to pierce the yellow ligament, just on the side of the bone, lateral as you can. And that's very important, because if you're not lateral enough, if you're too medial, you may dock your instrument right on the exiting nerve root or traversing nerve root, and like that you can damage them. So this is the intraoperative image. As you can see, with the coagulation, I am coagulating, and then I am trying to pierce the yellow ligament. And then this is the next picture. You have pierced the yellow ligament, and then at that point, you're advancing your working cannula in that opening that you have created. At that point, the working cannula is docked, so it is resting on the facet. This is medial, this is lateral, up and down. So you are docking your cannula on the facet, and then you develop that opening, and then you slide your working cannula inside. Always remember that the bevel is pointing outside. Here, the bevel is pointing outside, so you're docking the bevel on the facet, and because the bevel is laterally, medially, you have a good window and visibility to work and to generate that. You slide your instrument still with the bevel laterally, so like that, the sharp edge goes between the exiting or traversing nerve root here, mostly traversing nerve root here, and let's say if that's a L5-S1, that's going to be a traversing S1 nerve root. So you dock it just laterally to the traversing S1 nerve root. And after you you advance, you can see the dura, or you can see the traversing nerve root here, and you're already inside. And then this is the next picture. Quite often, if there is a disc herniation, you can see the nerve root flat, and you have to be very careful not to take that nerve root for ligament and start cutting through that nerve root. So this is more magnified. You're closer. You can see the nerve root is flattened because there is a disc herniation underneath. So what you have to do is you have to use an instrument to medialize the nerve root, and then after you put the instrument, you rotate your dilator, you rotate your working cannula, so then the bevel becomes medially, and like that the bevel is retracting the nerve root, and you have the disc right in your field, and you can start taking the disc. You can see the disc here. You just have to take it out, and that's the surgery done. And thank you so much for your topic. We can talk a lot about that. I think this will be the first step for you, and I think this is something that can, if you apply that, you can maybe attempt starting in the beginning. You can be with, I advise you for the first maybe 5-10 cases to be with a proctor, a surgeon that will be with you, that will direct you what to do. He will tell you what to do and what not to do. Thank you.
Thank you, Dr.
Thank you
Nikolay.
so much.
It's very interesting topic. Okay, you can go, Dr. Nereza.
I just wanted to say thank you so much for a great topic. And Dr. Nikolay Peev is traveling all around the world with great courses, and I got the privilege to organize one of the courses first in Central Asia, and indeed very important topic, important for young neurosurgeons as well, and the brilliant anatomy as always.
Thank you, Nargiza. We are going again in Tashkent just next week. We are organizing a course in Tashkent exactly on that. The course is starting Friday and Saturday.
Great. Okay.
Yeah.
I will try to contact some guys there as well.
Yes. Okay, any questions? I'm happy to answer.
So far, we don't have questions in the chat box, but maybe Professor Adnan, you would like to say some comments?
As one technique to learn it, but the one we need to know, as you said, it's need at least 200 cases to be more expert in one procedure. So about the different approaches and the different guidelines by the manufacturing companies like stores or Max Morris Mine, or they have different approaches for a single approach as transforaminal or biportal or monoportal endoscopy. From your advice, should anyone just start one approach and then go to the other approach, or you can start multiple approaches at the same time?
What I see happening around me, so I started first transforaminal. My first endoscopic approaches were transforaminal approach. I don't know if that's the right thing to do, because probably that's one of the most difficult approaches. What helped me is I was doing, before I start the endoscopic approaches, I had almost 10 years of minimal invasive surgeries So I had good understanding of the anatomy. I had good understanding of the cambium triangle, exiting nerve root, traversing nerve root, and all the relations there. So this is very important. So if you have a good understanding of the anatomy for some reason, then that's going to be a good start for you. It's going to be a flying start. So this was one factor for me. The other factor for me was that my practice involves a lot of injections. I do maybe 600 injections each year. So I do injections for pain relief for my patients. And quite often I do diagnostic. Let's say if I have somebody that comes with multi-level disease and I don't know exactly which level is the pain generator, I quite often will send them for injection. And I would do the injection myself. And like to develop that knowledge and the eyes for the X-ray. So you can read the X-ray very well. You start understanding the X-ray very well. And also you'll start understanding the trajectories. The trajectories are very important. So let's say if you're doing transforaminal nerve root injections, approach. So injections are something that you can consider. It's very easy for you to start doing them. It's very difficult to harm your patient, but actually quite contrary. If you start doing the trajectory that you need for transforaminal, let's say if you have foramen that's very narrow, and if you go a little bit more lateral, the way you do transforaminal approach, you're going to get in the foramen easy, unlike if you are too medial. So injections are very important. And the other important thing for me was that I had already, before I start, spinal endoscopy experience. So obviously that is far from spine, but that still gives you the reflexes and the knowledge how to navigate your endoscope, how to navigate the endoscope, to orient yourself on the endoscopic image. So these are things that you need in order to start any of these approaches. So if you need an anatomy, and that's a good understanding of the instruments that you have and to manipulate them. And you need, in that case, very good understanding of the X-rays. This is very important. So I think that this is what I'm going to tell you with regards of which approach many people will be starting with biportal endoscopy, because easy for you to start. If you are doing microscopic, biportal is not far from that, and with biportal you can do different decompressions. You can do decompressions way faster comparing to the monoportal. Probably biportal is the easiest for you to start. I think if you would like to start monoportal, laminar is easier than transforaminal. Maybe you have to leave the transforaminal for after you start doing well the interlaminar approach. And then the last thing that you have to consider doing is the transforaminal fusions.
Thank you, Doctor. I have another question. What is the time limits for each procedure for endoscopy? What time do you need to shift from an endoscopic approach to open surgery? If it's take a longer time, 1 hour, 2 hours, what is the limited time?
Yeah, so of course, when you start doing any approach, any procedures, you're going to take more time. But let's say if you see that you are working already, whatever approach, 2 hours, and you are not there, you haven't done significant advancement, you have to shift to something that is familiar for you and that you can do it. But I don't really have a cutoff time, but I think probably 2 hours. If you cannot perform a discectomy in 2 hours, 2.5 hours, simple discectomy, that's too much, maybe too much for your patient. And then you have to do something that you're familiar.
Okay, thank you, Doctor. Dr. Ahmed,
Pleasure.
do you have any questions?
And thank you, Professor
Dr. Ahmed?
Nikolay, for this fantastic presentation. It was very nice cases and very nice discussion. So thank you very much, and it's an honor for us to have you with us.
Thank you so much. Thank you for inviting me. It was my great pleasure.
Thank you.
All the best. Good luck. Have a good day.
Thank
Thank
you,
you very
Dr.
much,
Nikolay. We
Professor.
will be in touch soon.
Thank you. Bye-bye.
Thank you so
Tahliel
much.
Nagiza.
See you next week.
See you
Thank
all.
you.
See you. Dr. Ahmed. Thank you,
Okay.
Dr. Ahmed.
Thank you, Dr. Adnan, for participating with us. And thank you, Dr. Nargiza. And also thanks to Professor Nikolay for his participation. So see you all, inshallah, next
Probably
week.
he's busy.
Yes, he
Yes.
was
Okay, see you.
doing surgery,
Next week.
but he finished on time. And maybe now he will go for other surgery. So thank you, everyone, and see you all
Okay.
next week, inshallah.
Next week. Thank you.
Okay, see you
Inshallah.
soon, Dr.
Bye-bye.
Ahmed. Goodbye.
Thank you.